A very good evening to one and all. It gives me immense pleasure to invite you for the classroom series of Neurocritical Care Society of India. Today we have with us Dr. Pramod, who is presently working as Assistant Professor Neuroanesthesia and Neurocritical Care at MS Ramaiah Medical College and University. Pramod has been my colleague at NIMHANS. He's done his DM neuroanesthesia from NIMHANS, followed by training in the UK. So he'll be speaking about weaning patients with neuromuscular disease, the how, when, and what. Welcome, Pramod. Over to you.
Thank you, ma'am. Thank you so much. Hi, everyone. Good evening. So, I'll be just briefly discussing about how we should wean these patients with neuromuscular diseases and when should we take a call whether to do a tracheostomy on them or whether to prolong the ventilation, or what do we do if we end up in failed weaning in these patients. Are there any techniques to probably increase the probability of weaning in these patients? So, to give you an outline of today's talk, so we'll have a brief introduction about the diseases per se and what happens when these patients go on mechanical ventilation, and how do we predict which patients would lead to prolonged ventilations and which patients would lead to getting tracheostomized at the end of, during the progression of their disease. And how do we assess these patients, whether they are fit to be extubated or to be weaned? Is there any protocol to wean these patients, and how do we wean these patients? Or should we tracheostomize these patients? And let's see if there are any technique to reduce the weanings as well. So the classical examples, as everyone is aware about the Guillain-Barré syndrome and Myasthenia gravis, upon which my talk would be majorly aimed at today. So GBE syndrome is an acute autoimmune polyradiculopathy neuropathy, which is got a considerable morbidity, which presents as a progressive ascending symmetrical flaccid paralysis involving all the limbs. And the mortality is been varying depending on different case series of different studies. It's around 1 to 18%, and it's around 20 to 30% of these patients would lead to respiratory paralysis, and out of which will 20% might need mechanical ventilation, and 30% would leave behind with residual weakness at the end of 1 year, and 3% will have a recurrence. So the variants, as we already aware that there are four major variants: acute inflammatory demyelinating polyneuropathy, which accounts for the majority of these patients, and we have motor axonal neuropathy, sensory motor axonal neuropathy, and Miller-Fisher variant, which are of less common nature. So what happens in GPS which leads to respiratory failure? It was in the year 1859, Landray initially found out that there is an ascending paralysis and the risk of aspiration, which they named as respiratory failure in these patients. There are four major factors which would lead to respiratory failure in these patients. The first one being the upper airway dysfunction. The second two most common are inspiratory and expiratory muscle weakness. All these leading to pulmonary complications would lead to respiratory failure. So this is a just brief line diagram which shows us what's the relation between the weakness and the progression of the disease and the level of antibodies and the infection. So as you can see here in this diagram, we see that as there is a prodromal infection in all these patients, and somewhere at the level 0, that is the week where they present to us, the weakness is still not set in. So the weakness starts setting in the initial first week. As you go across the 4 weeks, weakness tends to increase and peaks somewhere between 2 to 3 weeks and starts improving as the course of the GPS. This is the normal course of GPS, and this is normal the antibody titers which go up at the peak of weakness and then start to taper. So what exactly happens to these patients before ventilation and after ventilations? So before ventilation is majoritarily the somatic nerve damage and the autonomic nerve damage, which lead to dysautonomia and bulbar palsy, which ultimately lead to diaphragmatic dysfunction, dysphagia, and increased secretions, inability to cough effectively, and leading to upper airway obstruction and microatelectasis, which leads to respiratory failure. And we end up intubating these patients. So what happens once we put these patients on the ventilator? They're more prone for VAP, pulmonary embolisms, bronchitis, atelectasis, like acute lung injury. They may also have some sort of polyneuropathy or myopathy or ICU related weakness or even the diaphragmatic muscle weakness as and when these patients are in the ICU for prolonged ventilation. All this would lead to decreased pulmonary compliance and increase in the vascular shunts, pulmonary vascular shunts, hypoxia, hypercarbia, which would put us in a difficult situation to wean these patients. So, how do we predict which patient would probably end up getting intubated or mechanically ventilated at the end of 1 week when they present within the 1 week admission? This is then Erasmus GBS respiratory insufficiency score, which beautifully scores from 0 to 3 and the maximum score of 7 and the least score of 0, which would tell us that if the score is between 0 to 2, there is a low risk of 4% that these patients might end up in respiratory failure. Whereas, as you see, once the score increases on the right side, as the score increases, the risk of respiratory insufficiency and failure is predominantly high, which is more than around 65% in these patients. So assessing these patients within 1 week will give us an approximate idea about where such patients might land up at the coming in the as the disease progresses. This is one of the study which showed that there are independent predictors for mechanical ventilation. The two being the upper limb power of less than 3 and the bulbar weakness, which led to prolonged mechanical ventilation in these patients. And also there's showed that there is a when there is a preserved reflexes in the upper limb, which was independently associated with lesser need for ventilation in GBS patients. By far, this is the latest study in published in September 2023, consisting of the largest cohort over the past 2 decades in Italy. So they predicted the they found the predictors for respiratory failure in GBS and the independent factors being the older age people, patients with facial, bulbar, and neck flexor weakness, dysautonomia, and those who had axonal type of subtype of weakness on the electrical conductance studies, and those who had cardiovascular comorbidities like hypertension and ischemic heart disease, and those who had higher disability score at the point of admission were the independent predictors for respiratory failure and mechanical ventilation. But there was no association with abnormal CSF parameters, nor did they find any with the serology of the recent infections. And when they looked at the predictors for tracheostomy, the facial, bulbar, neck flexor weakness still played a major role in patients requiring tracheostomy due to weaning trial failure. And apart from that, the autonomic dysfunction and the cardiovascular morbidities and axonal type of subtype of GBS played a major role. So how do we assess the diaphragmatic functions in these patients and bulbar functions in these patients at the bedside? If you see a patient who is struggling to breathe or having a rapid shallow breaths, having a tachycardia, that's a danger sign. Or if he's having a psychotic speech and if he needs to pause in between to generate any word, that also is a danger sign. And if you see any of the accessory muscles being used either by visualization or palpation, or if you see a paradoxical inward movement of the abdomen during the inspiration, that tells you that there is a diaphragmatic weakness which is setting in these patients. Apart from, you can also visualize the weakness in the trapezius and neck muscles, which parallels the diaphragmatic functions. And the routine one which we use is single breath count in most of these patients. And there is if there is an increasing frequency of cough, particularly once you ask the patient to swallow, that is an important sign for bulbar dysfunction at the bedside. So what we do, we tend to intubate these patients electively whenever we anticipate that these patients might have might require prolonged ventilation or going into impending respiratory failure. We put them on a control mode of mechanical ventilation and give them a regular chest physiotherapy, do regular blood analysis, do a periodic chest x-rays, and do a culture sensitivities of tracheal secretions as and when there are infections in these patients, and put them on appropriate antibiotics and start weaning them as and when they are ready on pressure support or TPS trials. And if there are any accompanying fever and organ dysfunction, we do also treat them. So just a note on NIV in patients with GBS. It's currently not recommended because these patients tend to have associated with the dysautonomia and respiratory muscle weakness. And these patients, the dysautonomia itself will risk these patients whenever they are going in for an emergency intubation, and this may induce a life-threatening complications like labile pressures and hyperkalemia with use of succinylcholine. And patients usually remain weak and they will need a prolonged ventilation, so we don't tend to use non-invasive ventilations, rather we electively intubate these patients. So questions to be answered: which ventilation mode should be preferred to enable the respiratory muscles to both rest and not to waste? So let's put the patient on the ventilator. So the synchronous intermittent mandatory ventilation is no more choice. So any control mode of ventilation, either pressure control or volume control, to achieve a volume of around 10 mils per kg, has found that it prevents atelectasis in these patients and has a good it does maintain good compliance as well, and probably that would be ideal way to go to start with. And we'll still discuss as we go further when do we start these patients to give us spontaneous breath trials. And a note on should we put this patient on supportive ventilation or a TP's trial when we are conducting spontaneous breathing trials. The studies have found that lately the pressure supportive ventilation has more success at the end of weaning and weaning success in these patients. But when we look at reintubation rates, there is no change whenever we use PSV or a TP trial in these patients. So, which respiratory parameters should we assess or should be used to predict successful extubation? We'll see about it in the coming slides. And is there a role of NIV or high flow nasal oxygen? Definitely, yes. Probably you might have already started using the high flow nasal oxygen after the COVID, left and right. So, the high flow nasal oxygen and the NIV are coming up big time in these, especially in patients who are post extubated and might have a good successful weaning and successful extubation whenever we use these modalities. So what are the criteria to wean these patients? So once the patients are admitted, they would be probably started on the plex or immunoglobulins. Based on that, the medical condition, the GPS would start resolving eventually. That would probably lead to increase in improvement in the muscles, and patients should be hemodynamically stable and he should be awake. The RAS between 1 to -2, and they should not be on any sedatives. And patient should have good cough and he should be able to cough out the secretions well, and the saturation should be more than 90 with minimal requirement of fractional FiO2 of less than 40 and a PEEP of less than 8, and the respiratory rate should be less than 35 and should be having normal blood gases. And apart from that, the pulmonary functions, the forced vital capacity should be more than 10 mils per kg, the maximum inspiratory pressures of -20 and expiratory pressures of more than 40 is an ideal patient for us to go ahead and wean and extubate. But this is not the case. We don't get such beautiful patients in our ICU. We always have villains in the background. That is, we have factors which increase the load for respiratory muscles, that is bronchospasm, airway edema, alveolar edema, effusions, abdominal distension, infection, atelectasis. And when we look at the factors which decrease the neuromuscular competence, patient might be sedated, might be malnourished, might have electrolyte derangements, or in sepsis. So we might have to take in all these factors in account before we start weaning these patients or probably give an extubation trial or a spontaneous breath trials. So speaking of diaphragmatic function and weaning, it's found that the diaphragmatic weakness resolves much before the extremity weakness in patients with GBS. So timing of weaning should not just be gauged solely on the recovery of the extremity muscles. So should we assess diaphragmatic functions during mechanical ventilation in GBS and myasthenia gravis? Let's see as we go ahead. So when we speak of selective decontamination of digestive tract, that is with the proton pump inhibitors, it's found to decrease the duration of mechanical ventilation from 42 to 29. However, it does not improve the neurological recovery in these patients after 6 months. So what's the protocol we follow during weaning? So once the patient is comfortably breathing with rates less than 25, saturations of more than 95, requiring less supports of around 5 to 10, requiring less than 40% of oxygen. And on the day of weaning, patients should be propped up, connected to a T-piece with an humidified oxygen, and then do a blood gas analysis at the end of 1 hour. If the blood gas analysis is normal, continue for 4 to 6 cycles of weaning for 30 minutes on that day. And the weaning time has to be gradually increased by an hour per day initially, followed by 2 hours and 4 hours per day, consisting of 4 to 6 cycles per day, depending on the patient tolerance. So when we say weaning, we tend to get most of the patients who go in for weaning failure. So there are new definitions for weaning failure, and of which most of our patients fall in group 3A, that is prolonged weaning leading to successful weaning after 7 days or more after the first attempt. So again, the criteria for considering the spontaneous blood trials in general ICU and neurocritical ICU. The most of the factors in general ICU hold good even for neuro ICU. Apart from that, I've already enumerated the ones which are important for us, especially for GBS and myasthenia gravis, of which I also mentioned the maximal inspiratory pressure and maximal expiratory pressure. So how do we measure these? It's easier said than done. So maximal inspiratory pressure can be measured in a patient who is on a ventilator on a supportive mode of ventilation. So the formula to measure it is P minus maximal pressure drop during the expiratory hold. So you keep the patient on pressure support ventilation and then put an expiratory hold for around 15 to 30 seconds. And then go back in the screen and measure among which of the graphs did the patient have maximum drop during the expiratory hold. So you can see in this video as we put the patient on the expiratory hold. So for 20 to 30 seconds, we put the patient on expiratory hold and we ask him to take a deep inspiration. So patient keep inspiring, has a deep inspiration. So you let the patient inspire and then save the images and go back and check which of these has the maximum drop in the in the inspiration during the expiratory hold. And based on that, you can measure the maximum inspiratory pressure. The same thing holds good for maximum expiratory pressure. Instead of inspiratory hold, you put an expiratory hold and you get the maximum expiratory pressure. So speaking of diaphragmatic functions, this study done in Nimans showed that patients who are having, during the assessment of spontaneous breathing trials, they found that electrical activity from the diaphragm, a reduction in electrical activity as well as increase in diaphragmatic excursion were the indicators of successful breathing trial in these patients who had neuromuscular disorders. So the electrical activity of the diaphragm is generally measured using a NAVA catheter, and I'll speak about how the diaphragmatic excursion have to be measured in these patients. So when we speak of diaphragmatic excursion, it's majorly how is the diaphragm getting contracted during inspiration and how it's going to relax during expiration. So we use a curvilinear probe in the subcostal view and generally pointing towards the liver at the midclavicular line and the anterior axillary line. We point the cursor at the midclavicular line and the subcostal view. So as you see, this is a cursor placed here. So as during the inspiration, the diaphragm moves down. So whenever something moving towards the probe will have a positive deflection. So as and when the patient expires, the diaphragm moves up. So the whenever something moves away from the probe will have a negative deflection. So as you can see, the distance between the inspiration and expiration is called diaphragmatic excursion. Any excursion more than 15 millimeter is said to be normal and would lead to successful weaning in these patients. When we speak of diaphragmatic thickness fraction, it is generally measured at zone of opposition. That is that is a zone where the diaphragm is opposed to the chest wall. So that zone is generally between the 8th and 9th intercostal space, something posterior to your anterior axillary line. We place a high frequency probe horizontally, and this is how you see an image, the diaphragm and the chest wall. So we ask the patient to inspire and expire. So during the inspiration, the thickness of the diaphragm increases. During the expiration, it reduces. So the thickness fraction is calculated as inspiratory diaphragmatic thickness minus expiratory and divided by inspiratory thickness, which gives you a percentage. Any percentage more than 30 predicts a good weaning and successful extubation in these patients. So let's say the patient is on getting prolongedly ventilated and has a weaning failure and is not getting weaned. So should we go for tracheostomy or should we wait? So what are the predictors that tell us that patient would need tracheostomy upfront? So as you see, the median in this study, they have considered almost around 146 ventilated patients, and it has shown that the median duration of mechanical ventilation is almost 28 days. That is more than, almost a month. So most of these patients do get ventilated almost a month. So how do we know whether out of these patients, how many of them would probably need intubation more than 2 weeks, more than 21 days, and more than 28 days? So this is a study which showed at condition at the 1 week after intubation, those patients who were mechanically ventilated and who were unable to lift the arms, 77% of the patients ended up getting ventilated beyond 21 days and 68 were beyond 28 days. And those who were unable to lift the arms and had an axonal type of neuropathy even had worse outcomes, that is 93% and 89%. But those who are able to lift their arms at the end of 1 week, in spite of being on the mechanical ventilator, you can see the percentage is quite less. So ability to lift the arms predicts whether the patient might need prolonged ventilation or should we plan for tracheostomy in these patients. So why do we perform tracheostomy? Because it has a lot of complications to keep the patient intubated because of the endotracheal tube. There may be a laryngeal injury or probably laryngeal mucosal edema, vocal cord injury, and this increases the risk of fistula formation. And when we go ahead with early tracheostomy in these patients, it does reduce the incidence of VAP. It does enhance the patient comfort, improves the pulmonary toileting, and it does reduce the resistance to breathe. And it also allows the early oral nutrition, oral hygiene, and oral communication and out of bed mobilization. So when do we perform tracheostomy? So apart from the study which I already quoted, that unable to lift their arms from the bed and with an axonal degeneration, a week at the end of 1 week should receive tracheostomy. But there is another study which showed that lack of foot flexion and uh, lack of foot flexion or sciatic motor conduction block in ICU at the 15 days, in spite of immunotherapy at greater than 15 days, is predictor for tracheostomy. So we generally give a rough estimation of 10 to 14 days as a cutoff to decide whether to tracheostomize these patients or no, to avoid any further complications because of tracheostomy itself. So, what are the techniques to reduce weaning or improve the outcome of these patients and extubate these patients or early weaning? This is one of the case study in the year 2017, which showed that instead of alternate day plasma exchange, the daily plasma exchange has led to better outcome and early weaning from the ventilator in these patients. As you can see, the power of upper limb and lower limb was 2 by 5 and 3 by 5 on day 1, and as and when at the day 5 they continuously gave the plasma exchange to this patient. So by 4th day the patient was weaned off the ventilator, you can see, and he was able to stand, and the power improved to 5 by 5 at the end of 10th day in this patient. So do we repeat the immunoglobulins if there is no improvement or if the patient is requiring prolonged ventilation? So this is a case series which showed that 3 patients at the end of 40th day received the second dose of immunoglobulins, and after 5 days of the second dose of immunoglobulins, they were able to be they were ready for getting weaned off from the ventilator. And also they have found out that the autonomic failure or autonomic dysfunction was quite less after the second dose of uh, the immunoglobulins. But this was an old study, but the latest study has shown that it does not make a major role in giving IVIG repeatedly. So sometimes we might have also seen giving IVIG might improve the patient, again might reduce the increase the weakness. The again it will increase the muscle power, and again it will reduce. So this type of treatment related fluctuations are quite common in GBS, and somewhere sometimes even in spite of greater than 8 weeks, some patients keep deteriorating, which whom we end up naming them as chronic CIDPs in these patients. So, what are the strategies to increase the success rate after extubation in GBS and myasthenia gravis? This is an old study which showed that BiPAP with an inspiratory pressures of 18 to 8 and expiratory pressures of 8 to 14 would probably reduce the reintubation rates in these patients. This is one of the studies published in 2019. This study was conducted in the general critical care patients where they used NIV and high flow nasal oxygen. So they after in patients who are at risk of extubation failure. So they used high flow nasal oxygen along with NIV in patients who are extubated, and they found that using high flow nasal oxygen along with NIV reduced the reintubation rate and increased the extubation success, apart from just using the high flow nasal oxygen. So, speaking of high flow nasal oxygen, we might have to keep in mind ROX index. So, what is ROX index? It is saturation divided by fractional inspiratory oxygen divided by respiratory rate. So what does this tell you? Once we put the patients on high flow nasal oxygen after extubation, we might have to assess ROX index at different time points, let's say 2, 6, 12, and 24 hours, greater than 12 hours. So we always have to check what is the ROX index, and based on the ROX score, we should be aware of what is the predictive value that these patient might get reintubated or uh, might end up in getting reintubation, because as we know the ROX index of less than 3, this is an example given here. So this is the ROX index of 4.4, so which is greater than the score for predicted failure at 6 hours, that is less than 3.4. So this patient might tolerate high flow nasal oxygen, might continue on high flow nasal oxygen. Let's say this was a 2 at the end of 6 hours. So these patient might not tolerate high flow nasal oxygen. So it is advisable to check the ROX index at every second hourly, especially in these patients with GBS and myasthenia gravis. A ROX index at the 12 hours point probably would make a major role whether these patients might get reintubated or no. So, what are the parameters which myasthenic patients end up in ventilation? So, these are the factors that are going to precipitate the crisis in these patient myasthenic crisis. So, this study showed that the major culprits are infection, aspiration pneumonitis, and change in the medication, either steroids or increasing and reducing the pyridostigmine would probably end up these patients in crisis. So, what are the predictors in myasthenic crisis patients which would lead to prolonged ventilation or which would lead to extubation failure? So, the plasma exchange during myasthenic crisis has shown a significant association with early extubation, whereas male gender and an old patient aged more than 50 and those who have atelectasis VAP significantly contribute for prolonged ventilation. So when we look at myasthenia gravis, it's more of ventilated associated infections and ventilated associated uh, factors which contribute for prolonged ventilation rather than the disease per se itself. So this is a study just published last month, which was done in Germany, which analyzed a large cohort of patients to assess the weaning and extubation failure in myasthenic crisis. So they found out that the percentage of weaning failure was around 64.2%, and majorly accounting for again the old age patients having multiple comorbids and a late onset myasthenia gravis. And apart from that, as I mentioned, atelectasis and pneumonia, which are more of ventilator associated played a major role in patients getting uh, extubation failure or prolonged weaning. So even the weaning failure occurred in patients who are treated with IVIG, whereas the weaning failure was less patients who had plasma exchange or immune therapies. And they also found out that the extubation success was more likely during the window period of 7 to 12 days. So that gives us a rough approximation of when exactly these patients might get extubated, or what is the duration of these patients might get ventilated, or whom do we anticipate that will require prolonged ventilation or tracheostomy. So this Chinese study showed there are other factors like carbon dioxide retention before intubation and less activity of daily living at the first onset of myasthenic crisis plays a major role, not only in the duration of ventilation but also in the ventilation ICU stay in myasthenic crisis patients. So when we speak of cholinesterase inhibitors and myasthenia gravis, there are different school of thoughts. As we are aware, the cholinesterase inhibitors do tend to increase the secretions, do tend to increase the consistency of secretions, and thick secretions gets clogged into the endotracheal tube or the tracheostomy tube, might lead to difficult weaning in these patients. So certain school of thoughts say that we have to stop the cholinesterase inhibitors, but we can't do so in all the patients, especially in patients with crisis. Even though the receptors are inactivated, we tend to keep them on the cholinesterase inhibitors. So generally, sometimes if the cholinesterase inhibitors are stopped for any reason, once the patient is on the ventilator, during the time of weaning, we do have to restart them on the cholinesterase inhibitors. If not, we might have to continue these patients on cholinesterase inhibitors half the dose of whatever they were taking. So let's say if they were taking around 30 milligrams initially when they didn't have any crisis or they didn't end up on the ventilator. So you might have to continue around 15 milligrams thrice a day. So that is how you titrate the cholinesterase inhibitors in these patients. So we are all aware that thymoma would lead to myasthenia and myasthenic crisis and all that, and thymectomy probably would resolve these uh, myasthenic crisis and myasthenia gravis as well. But this is one interesting case study published this year in the month of January, saying that a patient who had no thymus, in fact, it was a fibrous thymus. As you see, this patient was in the hospital, received multiple IVIGs, but didn't show any improvement in the muscle weakness. So at the 70th day, the crisis, there was still two crises, and the titers were not coming down. So they performed an extended thymectomy, which was a fibrous thymus in MRI. They went ahead in doing an extended thymectomy, and they found out that the antibody titers started reducing in these patients, and even in fact, this patient was extubated. And as you can see, even the weakness in these patients didn't have any change or any improvement in the weakness till the time the thymectomy was performed. So it is still not sure whether the thymectomy in a patient who does not have thymoma, resection of such thymus would probably lead to improvement in these myasthenic patients. So, as we were speaking of diaphragmatic ultrasound and electrical activity in GBS, of the diaphragm in GBS, this study showed that monitoring diaphragmatic functions in patients with myasthenia gravis versus the minimal inspiratory pressure, which we measure in the ventilator. So, they compared these two in these patients and they found out that during weaning, the maximal inspiratory pressure increased slightly, but it kept varying unpredictably. But whereas rather the tidal volume over the change in the electrical activity, that is the electrical active change in the maximal and the least electrical activity during inspiration, this change was constant. And this change, as the muscle strength recovered, they found out that this tidal volume or change in electrical activity decreased. So you can see in this diagram, this is the patient who is getting intubated in ICU, who is having myasthenia. And as you go ahead, the patient is given steroids and pyridostigmine is restarted here. So you can see the inspiratory pressures going down. Whereas the maximum inspiratory pressures, when they measured, they kept fluctuating because it's more of patient oriented, and it's not, it becomes objective sometimes, it becomes subjective sometimes. Whereas the tidal volume over the electrical activity kept reducing as and when the patient was extubated. So they found that this is a more better predictor for weaning and extubation in these patients. So, to give you a take home message, so we have discussed so far how do we predict that which patient will probably end up getting ventilated beyond a week, beyond 14 days, beyond 21 days, even either it is GBS or myasthenia. And how do we assess these patients clinically, bedside? How do we assess these patients? And how do we use the ultrasound? How do we use the newer modalities of weaning in these patients? And how do we wean these patients? And when do we extubate? And if extubate, if not extubate, should we plan for tracheostomy? And what is the time point do we have to allow them to wait for the tracheostomy? And what do we have to do after we extubate these patients? And should we have to put them on NIV or HFNO to improve the reintubation rates? And what are the techniques for improving weaning? Is there any role for additional IVIG? Is there any role for regular daily plasmapheresis, or is there any role for thymectomy? So this is new schools of thoughts and different schools of thoughts with respect to cholinesterase inhibitors, and how do we go about it? So hope I have made certain points clear to all of you. I would like to conclude. Thank you.
Thank you, Dr. Pramod, for that very lucid and very extensive presentation on how do we approach a patient with neuromuscular weakness, and that's something. It's a great challenge to wean these patients out. So, in your experience, what do you think is a very important factor? How would you proceed in kind of assessing? You have outlined various things. So, how do you think what if you have to say a single best predictor, or what would you take to
So
initiate
this
weaning?
single best predictor would be especially in patients with GBS, the ability of foot flexion and lifting the arms on both the sides. So if there is any indication that patient is able to lift the arms over the shoulder level, and if there is any foot flexion, so we can still wait in these patients rather than going for tracheostomy, because these patients do tend to improve and we can go ahead and extubate these patients. But in most of these patients, we have encountered the autonomic dysfunction also playing a major role in these patients. So whenever we put these patients on, let's say, a TP trial, we end up getting failed weaning because of hypotension, because of arrhythmias. So treating autonomic dysfunction also plays a major role, especially in GBS patients. So that does resolve over the period of time, but we might have to probably treat them as and when we encounter such autonomic disturbances in these patients. With respect to myasthenia gravis, so continuing the cholinesterase inhibitors at least half the dose during the stay, even on the patient when the patient is on ventilator, probably would let the patient to retain certain amount of muscle action or muscle strength, rather than completely stopping them on cholinesterase inhibitors. And probably that is one thing which I would do routinely these days.
Okay. And one more important thing about these patients is also the nutrition. So these patients have a
Yes,
tendency to have a lot of muscle loss. So nutrition has to be taken care, because that's a again an important point, especially when they usually tire out during weaning, and that's the challenge here
absolutely.
to keep these patients going. And also you need to look at other factors, giving thromboprophylaxis and infection control. These patients are immunocompromised, especially myasthenia gravis, when they are receiving steroids and that. So infection control also is an important factor which could contribute, which could make the weaning even more difficult. So thank you, Dr. Pramod, for this wonderful
Thank you.
talk. On behalf of NCSI, we would like to see you on many more forums. Thank you so much.
Thank you, ma'am. Thank you so much.